Да. Доита симасте.
Thank you, Chairman, and I thank you for inviting me for this meeting. I'd like to talk about outcome of THA after previous hip preservation surgeries. I'm Dr. Ohashi from Osaka, Japan. During the progress of this plastic hip OA, you can see the superlateral subluxation of the femoral head is usually. To prevent such subluxations, some kind of osteotomies are indicated. There are pelvic osteotomies, such as Kelly osteotomy, RAO, PAO, shelf osteotomy, shoulder osteotomy, and femoral osteotomies, such as varus and valgus osteotomies. The Kelly osteotomy was performed at the age of 10 years old here, and after 33 years old, the progress of this plastic hip OA is prevented by this osteotomy. However, even if the osteotomy was performed, the progress of hip OA is sometimes seen. In such cases, total hip arthroplasties might be indicated. However, the total hip arthroplasties after osteotomy is not the same as the conventional primary DHA. For example, scar tissue formation and deformed bone geometry affect the surgical techniques, the radiological and clinical outcomes. Kelly osteotomy creates the neo-acetabulum by cutting the iliac bone. However, when doing THA after Kelly osteotomy, neo-acetabulum does not always support the cup. Here in this case, the cup was not supported by the neo-acetabulum. The self-oscillation has the same problems. You can see here that the cup was not supported by the formed acetabulum roof. In RAO or PAO, the acetabulum is osteomized and it is rotated to anterolateral direction. That means that the posterior wall is sometimes missing. You see that the massive bone, massive osteophyte at the anterior side of the acetabulum, but the posterior wall is missing. That affects the stability of the cup. In shoulder osteotomy, iliac bone graft was performed. In such cases, iliac bone deformity as well as abductor muscle weakness occurs. Seen in this case, the deformed iliac bone makes it difficult to identify the pelvic position during THA. After varus osteotomies, greater trochanter interferes the insertion of the stem. In this case, correction osteotomy should be done to insert the stem. And in this case, transtrochanteric osteotomy was performed to insert the stem. In varus osteotomies, medial neck interferes the insertion of the stem. In this case, we have to cut the medial neck to avoid the valgus insertion of the stem. So the purpose of my presentation is to investigate the clinical and the radiological outcomes of THA after previous hip preservation surgeries from our experiences. We operated 20 THA after acetabulum osteotomies and 20 hip THAs after femoral osteotomies, mainly Chiari and shelf osteotomies and varus and valgus osteotomies. And also we performed 10 THA after acetabula combined with femoral osteotomies, Chiari or shelf osteotomy combined with varus and valgus osteotomies. The average age at THA was around 55 and 60 years old, and the male-female ratio are same among three groups. We investigated the surgical outcomes such as surgical time, intraoperative bleeding, clinical outcomes such as JOS score, radiological outcomes such as the lucent line, loosening, cup height, stem alignment, and leg lengthening. Cup height was measured at the distance between inter-teardrop line to the cup center. The results: the interval between osteotomy and THA were around 26 and 32 years, and the interval between THA and follow-up was around 7 to 8 years. Surgical time was significantly longer, and intraoperative bleeding was greater after femoral osteotomies. Post-operative clinical outcomes were similar among three groups. However, the pre-operative range of motion was restricted in combined group. We found no lucent line, no loosening in our series. Cup height was relatively higher in acetabular group. Stem alignment is inaccurate after femoral osteotomy. Leg lengthening was greater in combined group. In discussion, we found some studies for the clinical outcomes of THA after acetabular osteotomies. These studies shows that the outcomes of THA after PAO combined with valgus osteotomy. Clinical results were poorer compared to the conventional THA. Socket position tend to be superior and lateral. However, stem alignment was not affected by valgus osteotomy. In this study, the radiological outcome was investigated after PAO osteotomy. As our results, the cup tend to be fixed in higher position. We could not find the studies for THA after femoral osteotomies, and it seems that THA after acetabular osteotomies is more difficult than THA after femoral osteotomies. However, our study indicates that the THA after femoral osteotomies is more complicated. In summary, THA after previous hip preservation surgeries has particular pitfalls. Surgical time was longer and intraoperative bleeding was greater in THA after femoral osteotomy. Cup height tended to be higher in THA after acetabular osteotomy. Stem alignment tended to be inaccurate in THA after femoral osteotomy. Thank you very much for your kind attention.
Спасибо огромное. Спасибо. Очень интересный доклад.